take blood from the first part of the aorta. So here's the right ventricle, here's the left ventricle, and then here's the aorta, which is leaving the left ventricle. So the first branch, the first artery that comes off of the aorta is the right coronary artery and then the left coronary artery. So the blood that comes the first off of the aorta is blood that actually supplies the heart and the heart musculature. So this is going to be one of those parallel options in the systemic circuit to supply the heart itself, right? So the heart, it would be sort of intuitive to think that the heart takes blood from or takes oxygen rather from the blood that's in the chambers, and that is not the case. There's no diffusion happening internally within the heart chambers. Instead, that diffusion happens across the capillary beds that are on the surface of the heart itself. So these are called the coronary capillaries or the coronary circulation. All right. Now we want to also think about the general anatomy of the heart, how it's situated in the thoracic cavity, and how it's separated from the abdominal cavity by the diaphragm. So your heart is typically the size of your fist. So smaller in adults, smaller in women, and then slightly larger proportionally in men. And so you're going to have a heart the size of your fist, sitting in your thoracic cavity, slightly askew to the left, and then it weighs about 250 to about 350 grams, and it is sitting on top of your diaphragm. So your diaphragm is this dome-shaped muscle that divides your thoracic cavity from your abdominal cavity, and so that's going to be sort of the seat or bed on which the heart can rest. Now, the heart is going to be separated from the cavities and the layers surrounding the lungs and the great vessels by its own pericardial sac. So the pericardium is the sac that surrounds the heart. It has different layers. It has an outer fibrous layer and an inner serous layer that helps to lubricate the heart and decrease any friction as the heart moves with the cycles of respiration. So it really allows the heart to sort of move with the phases of the cardiac cycle and the cycles of respiration, the diaphragm also elevating and descending smoothly because of that lubrication in between the layers of the pericardium. All right, so just to look at some of the anatomy of the heart as well. And then internally, it has 3 layers. You can almost think of your heart as being a giant blood vessel because it has the analogous layers that you would see in a typical blood vessel. It has the epicardium, which is the external outer layer. It has the myocardium, which is the thick muscular layer. This is where we have most of the cardiac muscle. And then it has the endothelium, just like you would find in a blood vessel, which is the inner layer of endothelial cells, the lining cells that are found inside the cavity. So those 3 layers are what help to form the structure of the heart. And most important would be the myocardium. The myocardium is what allows the heart to forcefully eject. And so the myocardium on the left side of the heart is going to be substantially thicker because the heart has to work against higher resistance out in the systemic circulation. We talked about how the arterioles are the branch of the vasculature that have the highest peripheral resistance. So the heart has to really work hard, the left heart that is, to overcome or to work against that peripheral resistance seen in the arterioles. And so it has a thicker muscle. All right. This is why patients that have chronic hypertension, for example, they're going to have a much thicker left heart, and they're going to have left heart failure that can sometimes be followed by right heart failure as well. Right. But as this muscle gets thicker, it makes the lumen or the chamber smaller, and so the heart becomes insufficient. We call this heart failure or heart insufficiency when the physical ventricle cannot pump forcefully enough, but it also doesn't have the space to fill adequately to be able to eject. So that can be seen with chronic hypertension as this muscle gets bigger. All right, let's talk about the valves here again. So we brought up the valves in terms of their function mainly to help blood flow in a unidirectional fashion, but the valves are going to be moving sort of synchronously with the phases of the heart cycle or the heartbeat, right? And so what actually allows the valves to open and close are these pressure differentials. these pressure gradients. Valves are not contractile. They don't have any muscle to them. They're actually connective tissue and a cytoskeletal element, right? Kind of this fibroskeletal ring. And so they don't sort of contract to open and close on their own. Instead, the pressure gradient across the chambers is what allows the valves to open and then to close. So in order for blood to move from an atria to a ventricle, the pressure in the atria must exceed the pressure in the ventricle, and then the valves will open passively in honor of that pressure gradient. Similarly, when blood leaves the ventricle and moves out into the arteries, the pressure in the ventricle is higher than the pressure in the artery, and the valve will open passively. When the pressure in the artery exceeds the pressure in the ventricle, the valves will also close passively as well. So all valves open passively and close passively based upon the pressure gradient or pressure differential across the valve. Okay, let's think about the function of the AV valves first. And we have two AV valves. We have the right AV valve, which is the tricuspid valve. And then we have the left AV valve, which is the bicuspid valve. And the bicuspid valve is named after the bishop's hat or the mitre because of its shape. Again, it only has two cusps, unlike the tricuspid valve on the right. And if you think about the function of both of these sides of the heart, you'll kind of understand why the tricuspid has an extra valve, because the right side of the heart has to face more volume. So the left side of the heart faces more pressure as it ejects. The right side of the heart faces more volume as all of that venous return from the systemic circulation has to come back into the right side of the heart. So the right AV valve has an extra leaflet or an extra valve in order to help it secure any backflow against the higher volume that's coming back to the right side of the heart. So those are your AV valves. And the way that they are structured, they're actually structured to the papillary muscles and the chorda tendineae. So here are the papillary muscles, which are these finger-like projections that stick up from the walls of the ventricle. And then the chorda tendineae are the fibrous cords that actually anchor the papillary muscles to the leaflets of the AV valve. So how this protects backflow is that when the chamber is relaxing, the papillary muscles are relaxed, and so the tendinous cords are sort of loose and floppy to allow the valve to open up, right? They're not tense when the chamber is relaxed. However, when the chamber is ejecting, because we want blood to go from the ventricle this direction into the artery and not this direction back into the atria, now we will see that the papillary muscles are going to be contracted. The fibrous cords are going to be pulled taut or tense. And so that is going to help the valves be anchored shut and prevent the forceful sort of ejection to push that blood back into the atria. So when the papillary muscles contract, they pull taut onto the tendinous cords or the chorda tendineae, and that is what keeps the valve from prolapsing into the previous chamber. So this is a feature that is only seen with AV valves, again, preventing the backflow of blood from the ventricle and back into the atria. All right. Alternatively, we can look at our semilunar valves. So these have a different location altogether, therefore they have a different structure and a different function. These only have two lunar sort of leaflets that dip back into the ventricle, and they communicate between the ventricle and the artery. So the right ventricle and the pulmonary artery has the pulmonic valve or the pulmonary valve. The left ventricle and the aorta, in between those, we find the aortic valve. So again, these are going to be sort of preventing backlog from the artery back into the ventricle in this position. And we're not going to see the tendinous cords, we're not going to see the papillary muscles here, but we will find these sort of deep cusps that sort of capture any backflow as that blood hits against the closing valve. So this is going to be the feature that prevents backflow in the arteries from the artery to the ventricle.